As far as the pulmonary valve, what are you seeing for percutaneous valve-in-valve replacements, either with tetralogy or pulmonary stenosis patients? I guess as far as outcomes, or I know it's not been around long enough to have long-term data, but on the short term at least.
So based on I think most of what's out there is anecdotal, particularly in the pulmonary position, but it seems to work. I don't know that we have any, like you said, long-term data, but I think that it's a compelling argument in favor of earlier pulmonary valve replacement, the knowledge that you could then, after an initial valve was placed, do a valve-in-valve procedure so that you could avoid a subsequent chest opening operation. Now, logically, you would think that there's a limit. I mean, you can't just put like 10 valves in a valve. Eventually, you know, the size of the RV outflow tract will get smaller and smaller and smaller and smaller as you go. But I think within limits, that should be something that should encourage us to try and avoid potential long-term sequelae from pulmonary valve regurgitation predominantly by putting in valves earlier.
A question kind of for your practical experience and with the percutaneous valves and the risk of endocarditis, and how do you approach that in your practice?
So that's an excellent question, and that's something that has come up because there was a lot of concern early on based on kind of early outcomes data that percutaneous valves may have a higher incidence of endocarditis than surgically placed valves. And that signal appears to be real. I'm not sure what it's coming from. I think that I don't know in terms of when those patients got endocarditis if that resulted in them needing to have the valve replaced again, or if you were able to treat through it and the valve still continued to function reasonably normally. The liability of right-sided endocarditis is substantially lower than that of left-sided endocarditis, but then again, the perioperative mortality for somebody who's otherwise young and healthy to have a surgically placed pulmonary valve is also very low. So it's hard to know exactly where that risk-benefit ratio is going to fall out, and I think that we're going to need more data on what happens to patients after they develop pulmonary valve endocarditis after a percutaneously placed valve to see if that's going to be something we're going to need to be concerned about in the future. So we got a couple questions here. Is there evidence to suggest that placement of a PA stent may decrease pulmonary stenosis and thus risk of future surgery to repair a valve? And how do you, manage regurgitation of the PA valve? So there is, I assume that you're talking about stenting before placing a percutaneous valve. That's what I make up maybe what the question is, and I think that's actually fairly common and almost becomes standard practice among interventional cardiologists who are placing percutaneous pulmonary valves, that they pre-stent to have kind of a nice straight flat landing zone on which to place the percutaneous valve. So it for sure is not detrimental and may be beneficial in helping to adequately position the pulmonary valve. And how do you manage regurgitation of the pulmonary valve? And I'm assuming that this is before percutaneous or before valve replacement. And if that's the case, actually, unlike the setting of aortic stenosis, where you only do transcutaneous aortic valve replacement for AS, most patients who receive percutaneous pulmonary valve are getting it for PI. So it works in the pulmonary position, whereas I think there's a lot of concern over using it in the aortic position. Average life expectancy for patients without fixation of Ebstein's anomaly. You know, that's an excellent question, and it's a question that depends a lot on how severe it is. As with a lot of these lesions, there's a spectrum of disease, and with Ebstein's anomaly, there are some patients who have a fairly minimally affected valve where the degree of apical displacement of the valve leaflets is not very significant, and they can go through life and have an incidentally noted Ebstein's anomaly on an echo for a completely unrelated reason later in life. The other end of the spectrum are young children who have such a small right ventricle and an atrial septal defect that they're profoundly cyanotic. And so I think it's dependent a lot on the degree of the disease. And I don't know that you can do a natural history that would be informative in that setting, because the the prognosis will be so dependent on the degree of the disease. Average life expectancy of repaired truncus arteriosus type 2.
I think we don't really know. All of the advancement of truncus repaired really came about after 1980. And even with that, current day mortality in the neonatal stage after truncus repair is 10% up. So I think it really depends on how well the repair went and at the age of repair. If it's not a later repair, the odds are better. If the repair was good, I think I don't think we have enough data to kind of know, but I would imagine that the life expectancy is pretty similar to anyone else who's had an RV to PA conduit, with the exception that the risk of re-intervention on that RV to PA conduit and multiple re-intervention is high.
What electrophysiology evaluation do you recommend for Ebstein's anomaly? So that's actually a very important question, and it's one that I didn't address in the lecture for lack of time. But in patients that have evidence of a bypass bundle or who have evidence of WPW, I think every single one of those patients I would send for electrophysiology study to see how rapidly conducting the bundle is. And on those bundles that are slow conduction, you can probably leave them alone and it's fine as long as they're not having problems with recurrent reentrant arrhythmias. But in patients that are found to have a rapidly conducting bundle, given that and the fact that we know that Ebstein's patients are predisposed to developing atrial fibrillation, which could be a setup for sudden death, I would recommend sending them for an ablation. So anybody who has a manifests pathway, a manifests WPW pathway, I would send for EP study. The other setting is patients who are going to go and have surgery. You will do a study upstream of surgery just to see if you can tickle their heart and make it misbehave. Because if you can potentially do a maze at the time of surgery and prevent atrial arrhythmias longer term. So those would be the two settings in which I'd use an EP study. Do you test for 22q11 in your clinic or send untested conotruncal patients to genetics?
Yes. I've done it both ways. I think for 22q11, we've done it where normally you can just do FISH analysis, but we know that the sensitivity of FISH analysis, I think, is less than microarray. So now the standard is to send a microarray for 22q11. The trouble we get into in our clinic is that this test is very expensive, and most often you need prior authorization, and usually the genetics counselor or the genetics clinic is more equipped to do that. And also, I think for my preference, I send everyone to genetics because I think they can speak more broadly about the specific risks. Depending on the family history, they usually do a very thorough 3-generation family tree, look for other congenital defects or abnormalities, and that plays into the risk as well. But I do discuss this possibility of 22q11 with every young patient that is thinking about having kids.
And what is the consequence of George's symptoms, treatment, imaging modality?
So this is not my area of expertise, and if you looked out there, there's actual practice guidelines for management and surveillance of patients with that George syndrome. It's important to distinguish between the genotype of the 22q11, which can be completely not apparent, and then the phenotype, which is the George associated with other skeletal abnormalities, hypocalcemia, with the George, there are practice guidelines, and I don't know too much about them, other than we know that there's certain risks that these patients have even in their future with the George. They have increased risk of early onset Alzheimer's. For some reason, their mortality is worse, and we don't really know for sure.
I was interested with your comments about the mechanical valve and the pulmonary position. Actually, last night at the dinner, there was a patient there that's 27 years in on her mechanical valve in the pulmonary position. One of the only one I know, but I know she's one of the few that's in this massive, medical center. So it's pretty cool. But as far as something like the onyx valve or something that has a low INR, approval in the aortic position, is that something that's viable in the pulmonary position or more viable as a mechanical valve in that position?
That's a great question. I think I don't see any reason why it wouldn't be. I might be slightly concerned about having a lower INR target in a system that's a lower pressure system, because the lower pressure system is what we think may be responsible for the excess of thromboembolic or valve thrombosis complications with the tricuspid valve on the right side of the heart. And so, it just hasn't been tested, but I don't see any reason why it wouldn't potentially work.
I guess with the reduced risk, could you still maintain a great, normal INR of 2.5 to 3.5 and reduce that risk of that lower velocity, risk of thrombosis, and basically negate, this is the theory, negate the risk of having that mechanical valve?
That I don't know, but it would be, I don't see any reason why it wouldn't be worthwhile to test for sure.
I had the same question myself. I was going to find the surgeons and ask, just because we know all of this data coming out with the onyx valve. I have a couple of patients with mechanical pulmonary valve, and they do tend to run their INR higher than even the mitral goals. So I think it's a very valid question. I'd be interested to see if anyone had an experience with the onyx valve in the pulmonary position.
I was going to comment a little bit about the mechanical valve. So we've had a few patients who've had mechanical valves put in other countries in the pulmonary position and tricuspid position, seem to be doing fine. But this really came up when a medical student who had a connective tissue disease who needed all 4 valves eventually done. He came to us and to our team and said, I want you to put in 4 mechanical valves. And we said, what are you talking about? We don't do that. That's not something that's acceptable. There's thrombosis risks, all these comments. And he said, show me the data. And so we started pulling data. He had already had a whole folder full of every paper that existed on mechanical pulmonary valves, and we started looking at it, and we looked at our own data, and he was right. It's really hard. This belief that you get more thrombosis in the right side of the heart is almost a belief more than it is a real proven fact. So, and lo and behold, this is about 4 years ago, and this gentleman, he's now a resident, and he has 4 mechanical valves, and he's, this is an anecdote, but an anecdote of someone who is informed medically, who forced us to really look at where our belief comes from. And I'm not sure that you can't do mechanical valves. Now, I think mechanical valves in general have problems in that you have to be really, really vigilant with anticoagulation, and you don't have transcatheter options if there's a problem in the future. So I think there's issues from that perspective, but I hear what you're saying, that I'm not sure that we're so strong in our belief.
So I think we'll finish the question and answer section for this first part and move on to the next session, and I'll turn it over to Tom Young.